Dr. Elbogan for a very warm welcome and a thank you for the invite to for me to come here and talk to my colleagues here at Harborview Medical Center and at the University of Washington. And the topic I chose today was external ventricular drain, and that's something that I've been working on since my early career in anesthesiology and then in neurocritical care. And being an anesthesiologist and a neurointensivist and talking to a group of neurosurgeons, I think this is a topic that we all are very familiar with. And I think what I'm going to present to you today is some of the things that are going on from a neurocritical care perspective in regards to quality improvement, performance measure or process measures, and kind of where is the data regarding kind of EVD management, let's say in the US and maybe worldwide. There's some data that I'm going to share with you. So I have a couple of disclosures obviously to talk about, and none of them are relevant for this particular talk. And we're going to go over some brief introduction to kind of the history of external ventricular drain management in the US, and then talk a little bit about epidemiology of external ventricular drain placement, and then touch on the guidelines and some recommendations from the Neurocritical Care Society as well as the Society for Neuroscience in Anesthesiology and Critical Care, and then talk about some quality improvement initiatives, some quality improvement data from Harborview as well as some of the data in the literature, and then I'll leave time at the end for questions and answers. So as you all are aware, I think this history is probably not very familiar with everybody in the audience. About ventriculostomy via borehole, probably about 100 or so years ago now, and to the recent, I would say fairly recently, we talk about obviously the exposure, I guess, of neurocritical clinicians to the guidelines and recommendations that are coming out from the NCS as well as the SNAC. And that's pretty recent, back probably from 2011 onwards. So in the last 10 or 15 years, we've seen a significant, obviously, output of data from various institutions, US and worldwide, and we'll touch base upon them in a little bit. So it's estimated about 25,000 external ventricular drains are placed in the United States every year. And this is from a data from a national inpatient sample study published in 2008. And the three most common diagnoses for which external ventricular drains are placed are non-traumatic subarachnoid hemorrhage, intracerebral hemorrhage, and obstructive hydrocephalus. And I think in the recent few years, obviously there is some data and evidence in the VTF guidelines regarding external ventricular drain management in patients with traumatic brain injury as well. If you look at this particular paper back in 2008, the median hospital stay for these patients with EVDs were about 13 days, and the discharge mortality was around 26%. And it's obviously unclear from this particular study whether the external ventricular drain placement in patients of severity. So I think they didn't look at severity, so the administrative database obviously. So there's very little granularity in the information regarding, the specific demographics and the clinical characteristics of patients on whom ventriculostomies were placed. And so that's something that I'm interested in working on, and I'll present some data here from Harborview Medical Center that we place about 250 or so EVDs every year at Harborview, and perhaps around 50 or so EVDs at the university hospital a year. And some of the data that I'm sharing here is from our 2014-2019 Neurocritical Care Service admissions database. And so patients with EVDs comprise about 13% of all our Neurocritical Care Service admissions. And the proportion of patients with EVDs are obviously more for subarachnoid hemorrhage. That's probably the most commonest diagnosis for which EVDs are placed. So about 57% of all our subarachnoid hemorrhage patients receive an EVD at some point during their hospital stay. About 23% of patients with non-traumatic intracerebral hemorrhage, and about 3% or so of our patients with traumatic brain injury, either in isolation or with another type of intracranial pressure monitor. Severity of injury graded obviously by the admission Glasgow Coma score. So the EVDs are not necessarily placed only in the severe grade patients across all disease processes. There are quite a few patients, about close to about half of the patient population here that get EVDs are categorized in mild severity. So, but at the same time, the implications that these EVDs are maintained for a fairly long time, and we talk about 270 hours, that's probably about 12 or 13 days, if you will. And if you calculate the number of hours that our patients probably in the last 5 years have about close to 290,000 hours. And I bring that point out because every minute, every hour a patient is exposed to an extraventricular drain, there's always a concern for over drainage, under drainage, and then there are a lot of transport that happen in patients with extraventricular drains as well. And so some of the data that we're going to share is looking at all of these aspects on patients with EVDs. The ICU length of stay for patients with extraventricular drains is almost 4 times that of patients without the extraventricular drains. And similarly, with the hospital length of stay as well, is about twice as much as the patients without extraventricular drains. And our overall mortality, again, this is all-cause mortality, is about 21% of patients with EVDs versus 11% without EVDs. Granted that mortality, majority of the mortality is via transition to comfort measures only. And 35% of the patients with an EVD are discharged home versus about 55%. Again, this is all comers. This is not adjusted by severity of illness. So if you look at the literature over the last 30 years or so, and I did this literature review from 1975 to 2019 using PubMed and using extraventricular drain and ventriculostomy as keywords, excluding patients. I mean, when you do ventriculostomy, there's third ventriculostomy also in the operating room, comes as a big proportion of these patients, and excluded patients under the age of 18 years. And look at specific domains like indications for use, whether it's subarachnoid hemorrhage or TBI or obstructive hydrocephalus device, meaning what catheter type, is it antimicrobial impregnated, non-antimicrobial impregnated, and then management practices and guidelines, and then drug routes. And we're all aware of the CLEAR 3 trial talking about intraventricular TPA in patients with subarachnoid hemorrhage or with intraventricular hemorrhage. And placement, for example, things that have advanced over the course of the years. For example, navigation to use for placement, simulation, and that's something that probably our residents, train when they go for the boot camp, I believe, every year, is that, how to place EVDs. And then infection, EVD-associated infection and antibiotic prophylaxis, and then obviously hemorrhagic complications. So overall, I'd say majority of the data that is published is in the realm of infection or infection prevention and antibiotic prophylaxis. I think that's the key because, like any other catheter, the patients with extraventricular drains are also at high risk for developing ventriculitis or ventricular drain-associated infections. And obviously, placement and hemorrhage, or obviously, and indications happen to be also among the top 4 domains that we looked at. Drug route is only a small proportion of the studies, and again, that's around. So we screened 4,400 articles, and the total articles included is around 460. And then you look at these articles over time, and you see that the bulk of the articles start to appear in the literature somewhere around 2008 and onwards. And in 2011 is when the American Association of Neuroscience Nursing published the extraventricular drain and lumbar drain management guidelines. 2016 is when the Neurocritical Care Society EVD guidelines came out. And 2017 is when the SNAC EVD, perioperative EVD guidelines came out. So this significant abundance of literature is very recent in the last 10 years or so. And that probably dictates to, I guess, the awareness of extraventricular drain associated events, if you will, infection being one of them, in the neurocritical care arena. So what do some of these guidelines and recommendations mean? So I put forth here 3 separate papers. So the first paper here is published by the American Association of Neuroscience Nursing, which I talked about in 2011. This next one is the Insertion and Management of Extraventricular Drains, an evidence-based consensus statement from the Neurocritical Care Society. And the last one is the one that I've been fortunate to lead the efforts from the Neuro Society of Neuroanesthesia and Critical Care in 2017. And we're going to touch base upon some of the highlights from all of these publications. So from the Neurocritical Care Society, so they categorize recommendations and good practice statements. So you can see there's several of the practices that we have are based on strong level of evidence, but some of them are not, and quite a few of them are essentially lacking strong evidence but are almost considered standard of care. So location of placement of EVD, I think this is less of an issue probably in the US than in other nations around the world. And one of the studies that we conducted on hospitals in Thailand actually placed EVDs in the operating room. All the EVDs at their institutions or in hospitals are placed in the operating room compared to the intensive care unit. However, as we know, the prevalent practice here, Harvard, and other probably institutions around the US is majority of EVDs are placed at the bedside, probably in the non-operating room setting, either in the emergency room or in the neurocritical care unit or an intensive care unit. VT prophylaxis considerations are pretty standard. There are many institutions which may delay the initiation of chemical prophylaxis in patients with extraumental drain for the concern of hemorrhagic complications. And that means that patients may remain on just compression devices for days or weeks on until the extraumental drains are actually removed. If you compare that practice to our practice, obviously, any patient with extraumental drain, depending upon the primary etiology or the diagnosis for which EVDs are placed, once the hemorrhage is stable or the aneurysm is secured, we move on to chemical prophylaxis, and we've been very consistent with that, but that's not necessarily the practice at other institutions in the country. And so these guidelines and recommendations are definitely going to make some change in the practice across the other institutions. They talk about anatomical landmarks and imaging assistance, which forms a core of how we place ventricular drains. And then there has been a lot of debate and a lot of change, perhaps, and a lot of variability in practices regarding antimicrobial prophylaxis. Now, while most institutions will give at least one dose of antimicrobial prophylaxis before the external ventricular drains are placed, there are still institutions in the country which may continue antimicrobial prophylaxis for the duration of the external ventricular drains. And the reason for them is that most of the institutions may not necessarily place an antimicrobial impregnated catheter. They may place a non-antimicrobial impregnated catheter, but still they do. And I'll show you data from a survey of neurosurgeons a few years ago, actually talking about this particular thing. And one thing to remember is antimicrobial catheters are so commonly used in our institution, but that is not the practice in the United States and worldwide. I mean, there's definitely a cost associated with it. You can argue that the cost of a ventriculitis will obviously is higher than the cost of putting an antimicrobial catheter. At somewhere in the cost of, I think, $4,000 versus $100. I think it's kind of the cost differential between antimicrobial and non-antimicrobial impregnated catheters. And intraventricular antibiotics for refractory ventriculitis, something that we rarely, we see rarely that patients actually develop ventriculitis from an EVD, and I think at least in my practice here, it's even rare to see just use of an intraventricular antibiotics for management, obviously for refractory ventriculitis more than a primary treatment modality. And then there's obviously data recommending against routinely changing catheter sites. Now, remember when I did my residency back in the early 2000s, for central lines, I mean, we used to have a pretty much a policy that central lines were routinely changed after day 3. So everybody in the ICU at third day who had a central line, we used to change the site of these central lines. And the argument at that time was, well, you change the site to reduce the risk of infection. But you're actually probably increase the risk of complications with repeated central line placements. And something that the guidelines recommend is not to routinely change the site of the catheter just because the catheter has been in for a certain amount of time. And then avoid routine CSF sampling. Now that is something that the data supports. So what is routine CSF sampling? Now certain institutions may sample only when the patient is symptomatic. When the patient is symptomatic and there is high clinical suspicion of ventriculitis, that's when the CSFs are sampled. Our prevalent policy is to sample here at least Monday and Thursday, and I believe, I'm not sure of the U, maybe the same policy of the U as well. And that's again, there's something to consider is what is the association between the routine CSF sampling and the risk of infection. A recent study in France actually challenged that notion that in one of the institutions in France where they did routine CSF sampling, they actually saw a reduction in the rates of ventriculitis. Again, the practice, the management practices are quite different. It talks about, is there an EVD management bundle? I mean, that's really what it comes down to is how are we inserting the EVDs? What kind of precautions are we taking when the EVDs are placed? And how are we really maintaining them? I think that it comes together in form of a bundle as opposed to individual components. But when you talk about individual components, and we'll talk about what a bundle might actually contain, is all of these things in a bundle in a very standardized form. Some of the good practice statements that came out from the NCS guidelines include training and mentoring and quality for personnel placing EVDs. Obviously, EVDs in the US and worldwide, I think majority of them are placed by neurosurgeons. There's a minority of them may be placed by neurointensivists, and a very small minority. I think there's one article recently in NCS about nurse practitioners actually placing EVDs in the ICU. But again, the prevalent practice is for neurosurgeons placing EVD, and based on our recent CQI, I think we've already taken steps in terms of mentoring junior neurosurgeons as they place EVD to get familiarized with the technique and reduce the risk of adverse events. Correction of coagulopathy obviously is, again, is best practice statement, because there is really no strong evidence to support, let's say, a specific platelet count, which is safer, at which EVDs can be inserted or maintained and removed. But I think consensus probably dictates that I think most EVDs are probably placed with platelet counts in excess of 100,000, and also assuring that the platelet function is normal regardless of what the count is. And correction of coagulopathy as well, INR goal and obviously PTT goal, and then obviously reversal of any of the anticoagulant and antiplatelet therapy that patient may be on before EVDs may be inserted. And then obviously we talked about routine CSF sampling and avoiding routine CSF sampling and obtaining CSF only when clinically indicated. And EVD weaning, I think there's a lot of practice variation obviously with EVD weaning as well. There are some proponents of what they call fast EVD wean versus slow EVD wean. And there is also some data in the literature regarding management of even subarachnoid patients with an EVD closed to CSF drainage, and only using CSF drainage as a modality when obviously the clinical exam or intracranial pressure may actually dictate. And then some of the thing at the time of obviously insertion. I think insertion is obviously the key time period for which most of the infections are introduced for all catheter-based infections. And again, this manipulation of the system as little as possible. I mean, exposing the system to repeated draws of CSF or injections. And something that is interesting is, at least in the anesthesia literature, and I'll talk about that, is EVDs can be a route of medication insertion, not necessarily antibiotics, but any type of medication. And we'll talk about what those medications are. You'll be surprised to hear some of the case reports that are out there and what has been injected through the EVDs. We talk about perioperative management of patients with extraventricular, and this is a topic that is dear to my heart, because I think as anesthesiologists, management of patients with external ventricular drain is not in our curriculum. And we are not taught formally how to manage or how to take care of even external ventricular drains. So something that I've been working on is to kind of probably bring that back into the curriculum, that not all ICP monitors are same, and not all drains are same. So there's something unique about these patients who receive an external ventricular drain, who may be drain dependent, who may come to the operating room or the interventional suite for a variety of reasons. And as anesthesiologists, we should be familiar with managing a patient with an external ventricular drain, and need to know how EVDs are inserted, maintained, and the knobology and the whole nine. So what we did is, as part of the guidelines and recommendations, actually very, very basic information. What should be done when you're doing a preoperative assessment of a patient with external ventricular drains. And this is important information that you need as you're bringing the patient, let's say, from the intensive care into the operating room. What's the baseline neurological exam? What is the intracranial pressure trending? What's the CPP trending? Highest ICP, lowest ICP, and so on. Coagulopathy reversal. Very few EVDs are placed in the operating room, but yet, we need to be aware that what is the consensus? What is your institutional standard? And is there a national standard for these things? And medication reconciliation as well, as we talked about, DOACs or NOACs and antiplatelet therapy, and obviously our anticoagulation profile. EVD data. So EVD data that is very, very basic to all of us, that we all are familiar with the setting of the EVD. Whether it is plus 20 or plus 15 or whatever, or 0 is important in the operating room. Average CSF output per hour. I think that also is important, because you may clamp the EVD for a certain amount of time during transport or in the operating room until you reach a final position at which the EVD can be maintained open. And then clamp trial data. I think clamp trial data is something that is very underappreciated and underreported. And what I mean by that is, the nurses in the ICU clamp EVDs at different times during the day, when they do head of bed changes, when the head of bed or bed position changes, or when there is obviously position when they're doing nursing care. And these amount to small clamp trials, which over the day may give you a fair estimate of is the patient able to tolerate EVD clamping or not. And this is very important when you are specifically looking for transport. And especially, let's say, MRI. For example, MRI is something that we do quite frequently in our neurosurgical population. And unfortunately, there is no way to monitor intracranial pressure during an MRI. So guess what happens to those patients with EVDs that go for MRI? They're all head of the bed is 0. Everybody's EVD is clamped. and nobody's ICPs are monitored. And the MRIs typically take, let's say, 45 minutes to an hour, give and take, we are putting the patient in the MRI scanner coming out. So for an hour in their clinical course, whenever that MRI is happening, these patients are not monitored for ICP at all. And then so the only way we find out is either based on hemodynamic fluctuations like bradycardia, hypertension, or change in the neurological exam at the end of the MRI. And it depends on when the MRI is done. During the phase when the patient may be drain dependent, doing an MRI at that time may not necessarily be the best idea unless you are able to test the patient's ability to tolerate head of the bed 0 degrees and tolerate clamping of the EVD for a sustained period of time. The other things we talk about specifically to transport are that how are EVDs transported. EVDs are typically transported with the EVDs lying on the patient's chest as opposed to being mounted on a pole. Especially if you're monitoring ICP, you need to level and zero the external ventricular drain at the external artery meatus. And if it's not happening, you're probably not getting an accurate measurement of intracranial pressure anyway. It also subjects the system to spillage and contamination. And we had one case a couple of years ago where the EVD was left open and it was left on the patient's chest, and there was backfill of the CSF, and the patient developed ventriculitis. And then the clamp status open versus closed CSF drainage. And that's something that we have some data from Harborview talk about. The current practice, the hospital policies, the procedures across the United States and worldwide dictate that EVDs are transported close to CSF drainage. But there are certain patients in whom this may not be ideal, and this may actually amount to an inadvertent clamp trial in these particular patients. So something that we need to be aware of. And then intraoperative, obviously, management of EVDs include, EVD setup. There was one incident here we talk about here is that the patient's EVD was placed in the operating room, and the EVD setup, we mean the EVD system, the transducer, was connected to our pressure bag. If you've seen the arterial line pressure transducers, the EVD transducers are flushless transducers, but in this particular case, the setup involved the pressure bag and a flush transducer, potentially placing the risk of flushing fluid back into the intracranial compartment. Right? And then documentation. I think overall with EMR, obviously the documentation of ICP and is maybe better, but still CSF data, CSF output, CSF color, CSF consistency is very it's very varied in how people document this, and probably the prevalent practice that people do not document this as routinely as they should. And we created a checklist. Obviously, it's a pretty exhaustive checklist, but it kind of talks about all the components we just mentioned in terms of the preoperative assessment of patients, the transporting patient with EVDs, and then intraoperative management, and then what to do when you have a change in the patient's caliber. So, for example, if there's sudden decline in CSF drainage, or if there is no drainage from the EVD or lumbar drain, who should you contact? Not all the time do you have a neurosurgeon in the room. Not all the time you're doing a neurosurgical procedure. So who do you rely upon? Is it your attending anesthesiologist? Do you call the neurosurgeon in-house? Do you call upon the neurocritical care nurse? What about excessive output, and what that excessive output really means? And then what to do if there's sudden change in CSF color? And we see it all the time with the indication of rebleeding, let's say, when you're doing, let's say, an aneurysm coiling in interventional radiology suite. Or what about sudden loss or dampening of the ICP waveform? This is just things that are routinely seen, but there is very little probably appreciation of those things, especially when these things are done by probably providers who are not very comfortable in managing external ventricular drains. And last thing to talk about from the guidelines and recommendations are the Agency for Healthcare Research and Quality put forth these practices similar to what the NCS and the SNAC guidelines and recommendations will in terms of equipment setup, catheter insertion, prevention of CSF leaks or notification of analysis results, and their outcomes. I think the outcomes obviously that are reportable are EVD infection, and that's something that we report to Joint Commission, and that's something that will be a performance measure obviously in the coming next few months to years. So let's focus our attention to quality improvement, and what I'm going to talk about briefly is just reviewing our QI database. At least these are neurocritical care service QI concerns that are self-reported or referred to us from the neurocritical care service to look at obviously concerns regarding any aspect of patient care. So we focus specifically on QI concerns that were reported to us within the last 11 years or so, focusing on extraventricular drains. And there were about 31 of them, and if you look at the domains, I think we pretty much covered every single domain that we just talked about. There were errors in setting up, we talked about this in the anesthesia side of things, connected to a pressure transducer and a pressure back system, to leveling errors, to disconnection, to contamination, hemorrhagic complications, overdrainage, and transport-related complications. And one thing to mention here is obviously, I think we probably underreport hemorrhagic complications. Patients may have trachtomas, and the trachtomas, if you look at the literature, and depending upon the case series, ranges from 0% to almost 50% of patients may develop trachoma. But there are certain patients in whom trachtomas, result in obviously worsening neurological status. And I believe recently there was a patient whose bilateral EVDs developed significant trachtomas, and the patient ended up ultimately on CMO, but I think the underlying pathophysiology was also pretty severe as well. So not necessarily that these trachtomas in isolation may result in worsening of neurological exam, but in some cases they may. And really what really started our work here at Harborview was this particular case of intracranial hypertension in a patient who was coming for a decompressive neurosurgical procedure in the operating room, whose EVD was clamped during transport. So the EVD was clamped from the ICU to the operating room. It probably takes about, let's say an average of 10 minutes or so for the patient gets to the operating room. The first recorded ICP in the OR was 76. And the EVD was clamped, and all of a sudden when the EVD is open, obviously you see the CSF drainage and the ICP normalization. And that made us think, okay, what happens to those patients when you do transport them? And so some of the data that I'm going to share here is regarding risk of routinely clamping extraventricular drains for intrahospital transports, and then talk a little bit about the prevalence of EVD practices in the operating room, and maybe some practices outside the United States. And we did a study in a hospital in Thailand, and I'm going to share you some data there. So looking at intrahospital transport of patient extraventricular drains. So we looked at 207 intrahospital transport for which patients had EVDs, 178. And these were 178 transports across 25 patients during their entire intensive care unit stay, as long as they had an EVD. So most of the transports were for diagnostic reasons, either a CT or an MRI or a diagnostic angiogram, and a few of them were for therapeutic. So there are patients going for either an aneurysm or an AVM embolization or coiling, or going to the operating room for clipping or decompressive frenectomy and things like that. So most of the times when the patients are going for these transport, their baseline EVD clamp status is usually open, meaning that the patients are in the ICU with the EVD open at all times. And there are certain patients who are either probably going for ventriculomegaly screening for hydrocephalus in their later half of their subarachnoid hemorrhage, where the EVDs are then clamped and we get what we call a routine 4 MCT. So there are some of the transports are there as well, but majority of the transports are early on in their clinical course, early meaning in the first 72 hours or so after their injury. And we noticed that there were ICP complications in about 27% of these patients. And what I mean by ICP complications are either an absolute increase in ICP or a number greater than 20, or a relative increase in ICP compared to their baseline intracranial pressure in the ICU. And some of the things that are important are the higher the pre-hospital transport ICP, or transports for therapeutic interventions, or unscheduled transports, right? These tend to have higher predilection for developing a transport-related ICP complication, which means that those patients whom EVDs are clamped during transports are at risk for intracranial hypertension during transport. Unfortunately, and one thing that is important to recognize is that the data during transport is not is not synchronized to the electronic medical records, because our transport monitors do not sync back to our existing monitors in the ICU or in the operating room, which means that that data is missed. So the data we collected here is the last ICP before transport initiated and the first ICP at the time of the patient coming back to the intensive care unit. So I think there is still an opportunity perhaps to even collect transport ICP data, and that's something that we'll be working on probably in the next year or so, is to actually look at ICP, real-time ICP, CPP data during transport, as opposed to collecting data before and after transport.
And that's irrespective of the fact that they're being hand ventilated.
Correct. Hand ventilated, and most of them either are hand ventilated or they may be on a transport ventilator. Correct.
but there have been papers that show that's a big difference.
That's a big difference, absolutely, correct. You're right about that. And without any end-tidal CO2 monitoring.
Right. So their entitled CO2 might be 54.
Correct. So you're probably, yeah.
All right, I'll shut them down. I'm listening.
Okay. So looking at, so what are the practices, across the, so this is a single center study that we did at Harvard, but what are the practices across institutions in the US and maybe worldwide? So this was a survey that we conducted a perioperative external ventricular drain practice survey across anesthesiologists in the US and in Canada, Taiwan, India. The prevalent practice obviously is that, most ICPs or most EVDs are not transported mounted on a pole. And this is prevalent practice across institutions. Perhaps, as you can see, poles may not be available for patients for transport. And we see that all the time when you're bringing patients to the operating room. We have only one pole, the pole is occupied by drips. And then you have an external ventricular lumbar drain, which is sitting on the patient bedside. So these are really exposing patients to significant risk of over drainage or even under drainage, depending upon where the EVDs and lumbar drains are placed. And during transport, the prevalent practice is that most of the time the EVDs are close to CSF drainage, and a very small proportion of the times is the ICP actually measured. So this is real time. This is not just single institution practice. This is the prevalent practice across institutions in the US. And in Thailand, so we did a study of 58 hospitals in Thailand looking at external ventricular drain practices, insertion and maintenance practices. And the data here is that, same thing, EVDs are always clamped during transport and ICP is never monitored. That is the prevalent practice. And if we don't perform a clamp trial before the transport initiated, I think that this speaks for itself that this should not be the case. And they have obviously the data here regarding worsening of neurological status or ICP elevation is probably underreported because ICPs probably are not even measured routinely in some of these institutions, and they're measuring ICP only on selected patients whom they considered high risk for intracranial hypertension, and that's also an issue because we are so used to measuring ICPs real time and then recorded every 1 hour, but that may not be the practice in other institutions. Intraoperative documentation obviously is very low. That the CSF data or ICP data is documented routinely, less frequently than what it should ideally be. For example, in the ICU, the prevalent practice is to document the data in EMR Q1 hour. In the OR, a typical data obviously is blood pressure every 3 to 5 minutes, and all the other parameters are in real time documentation in EMR. But perhaps this reflects. There are still some institutions where EMR is not part of the anesthesia record, it's still paper charting. But yet, I think we can do a better job at documentation of ICP and CSF data on the operating room record. And then the one interesting thing that came out from this particular, again, this survey is of attending anesthesiologists who manage EVDs routinely in their practice. That comfort, self-reported comfort in managing EVDs played a significant role in how you adhere to existing guidelines. So, for example, if you ask this particular audience, so 80% of the survey respondents had no formal training in external ventricular drains, yet they managed patients with EVDs. And those that were confident and comfortable in managing EVDs actually did a good job in adhering to all this guideline, the recommendation that we put forward for SNAC. Which means that I think we need to do a better job at obviously educating anesthesiologists, both attending as well as trainees, in how to manage patients with external ventricular drains. And some of the adverse events obviously reported are overdrainage of CSF, spill and contamination, flushing of the catheter, and accidental injections. When I mean accidental injection, there have been case reports of anesthetic medications injected into the external ventricular drain, propofol, rocuronium, and that is because if you look at the external ventricular drain catheter, there are ports and there are sites where it's labeled CSF access only, but that can easily be a conduit for injecting medication. So if you're not careful under the drapes as to which tubing you're referring to, you can easily get into trouble with this. And so this is something that now with the guidelines and this particular survey, we are spreading awareness of these issues across anesthesia providers worldwide. And we talked about some EVD practice variations across the United States and worldwide. So based on our study in Thailand, all the EVDs are placed in the operating room, most of them. And there are some EVDs that can be placed in the emergency room or in the intensive care unit, but the prevalent practice is that EVDs are placed in the operating room. And the most common QI measure that is tracked is EVD infection. And I think that's a common EVD metric that is tracked across most of the institutions in the US as well. I think in a recent survey of neurosurgical colleagues, about 66% of the survey respondents said that at their institution, EVD infection is routinely tracked. A written institution EVD protocol. I mean, you'll be surprised that not many institutions, even in the US, have a written EVD protocol, which is updated with the recent guidelines. In Thailand, surprisingly, only 5% of the hospitals, which is about from 58, actually had a written institution EVD protocol. And most of the time it was left to either the attending neurosurgeon to manage the patient however fit he or she sees it. And what is the prevalent EVD infection rate across US or worldwide? I think in this particular survey we found out that about 50% of the hospitals report an EVD infection rate of less than 5% per year. Again, what is allowable? What is the acceptable EVD infection? We don't know. I think we don't have a very robust data to support that. Can the EVD infection be zero? And I think that's something that we need to obviously look forward to. And looking at sampling, I think here in this particular survey from Thailand, the practice there was routine antibiotic use until the EVD was removed, and they do not place antimicrobial impregnated catheters. They place non-antimicrobial impregnated catheters, and you're exposing the patient to obviously hospital-acquired infections such as C. diff. C. diff is very common in these patients who are exposed to EVD. And I think we have a paper from our group here which showed the reduction in the incidence of C. diff infection once we changed our practice from a routine prophylaxis to only single dose of antibiotics prior to EVD placement. And again, same prevalent practice in Thailand as well. Again, transporting patients with EVD clamped without ICP being monitored. So what are some of the QI initiatives that we can really focus on? So looking at operating room, intensive care unit, transport, and then non-ICU placement, I think we all need to be familiar with the setup documentation and QI reporting for the operating room, setup, insertion and maintenance bundle, and QI reporting. I think it's one important is to obviously look at our own data to make sure how good are we doing as far as infection rates are goes, as well as hemorrhagic complications as well. And then transport, I think this is an area that is clearly underappreciated as well, is the pre-transport risk assessment, and then having the ability to actually monitor ICP during transport and at locations which are remote from the intensive care unit. And so it comes down to is formation of an EVD bundle. I think EVD bundle will obviously address insertion, maintenance, infection surveillance, education, and QI matrix. And I'm going to point out to you the National Quality Forum center line bundle, and something that the Neurological Society is working towards creating such a bundle performance measure for external medical drain placement. And there are many elements that are common between a center line bundle and an EVD bundle. For example, obviously hand hygiene, barrier precautions, chlorhexidine, clean antisepsis, optimal catheter site selection. This particular is obviously, depends on, what equipment you're using to place an external ventricular drain, not necessarily the site. Center lines, we talked about femoral versus IJ versus subclavian. And then, obviously, the performance measure is going to be total number of intensive care patients on whom EVDs are placed, and the numerator is going to be on number of patients on whom the bundle was actually implemented. And I think that might be a performance measure that is upcoming from the NCS. So we'll have more information on that in the next 6 months or so. That may become a standard across all institutions in the US. And so I think when we talk about promoting a culture of EVD safety, we need EVD champions across all the disciplines that typically manage patients with external ventricular drains: neurosurgery, anesthesia, critical care, nursing. And I think once we come together and form our own institutional consensus and national, international consensus, I think we can promote a culture of EVD safety. So with that, I want to conclude by saying that obviously we need to be involved in more multidisciplinary meetings to review EVD-related QI concerns. There's definitely to be a collaborative effort between neurocritical care clinicians as to how we insert, maintain, and manage EVDs. And then obviously we need to take care day to day in terms of setup, insertion, maintenance, and transport with the goal of reducing EVD-related adverse events. I want to thank my collaborators on the projects that I've worked with EVD, especially Mike. I mean, fortunate to work with you on the Smart EVD trial, and hopefully to continue that collaboration in the future as well on EVD. And obviously, Pat Blissett, who is our neuroscience clinical nurse educator, she's instrumental in our institutional guidelines, and she's done a tremendous job in promoting a culture of EVD safety across the neuroscience and critical care nurses across the institution, and Dr. Gabriela for her support from the injury center. And folks from anesthesia as well as QI folks that have been helpful in data collection. So with that, thank you again for listening, and